My name is Dr. Pendirthi. I'm a pulmonary critical care doctor at Mercy in Springfield. Um, I don't know if I have worked with any one of you or if any one of you have done any rotations for either ICU or pulmonary medicine. The topic I was asked to give you guys was use of virtual care in pulmonology and critical care. Um, so let's get started as to what kind of actually drove or accelerated the decision of going into pulmonology and critical care for the use of virtual care services. So COVID-19, you all know, I don't know if you guys were in first year or you were in pre-med, but COVID-19 pandemic pretty much changed the healthcare landscape. It changed in terms of the resources that were required to manage patient care, in terms of what was available for the hospital systems to allocate, even for patients to get adequate care. It required newer technologies and newer approaches to provide care instead of the traditional way of doing it, where patients would come to an office or to a healthcare setting, and then we would provide care for that patient over there. So, a lot of things happened during the COVID pandemic. Because of the infection risk, there were no office visits for almost 3 to 4 months. And that's when we started providing a lot of care through virtual visits. Telemedicine as a service was available for several years. For more than 25 years, telemedicine was available, mostly in places which could not be reached or were not really accessible, or those which did not have high volumes for a full physician provider to go there and provide the care for just like one or two patients. So let's start about how pulmonary medicine and virtual care are connected and how it is being used in pulmonary medicine. So as we were talking, the first thing is the office or outpatient care. So starting 2020, the largest consumer of healthcare in US, which is CMS, or Center for Medicare and Medicaid, they allowed uh, patients to be seen by their providers or their physicians by just having a video visit. So what this means is the patient has ability for a device which has audio visual interface, typically a cell phone with a camera or a laptop or a desktop with a camera and a mic. And once these are available, patients can present their history, physicians could ask questions, and then physicians could review their lab work, their blood work, their x-rays, and their imaging reports. And subsequently, then they would come up with a plan to discuss with the patient. And essentially, what it would miss was clinical examination. There was no physical examination possible since it was virtual. This was slightly different from the telemedicine concept that was available for the past prior 2 decades. In that, the patient would actually go to a nearby healthcare center, and then there would generally be a nurse or a nurse practitioner or a PA who would examine the patient, and they would use like a virtual stethoscope, a virtual ophthalmoscope, and the physician remotely could examine the patient also. But with the newer ones, it's just video visits. And again, if you look at the utility of clinical examination in certain healthcare fields, where decision making is predominantly made on a lot of data, there these video visits were more useful. They were not useful for examining a surgical abdomen or an OBGYN patient, but they were definitely useful for patients who needed management of their asthma, or let's say diabetes or high blood pressure, or anything that would predominantly involve lab tests and medications. Okay. Now, coming to pulmonary medicine, the place where video visits were also being used was for to getting second opinions. It's common for patients to get a second opinion when they have complex lung diseases or rare lung diseases, where they can actually seek a consultation from a medical center that is not even geographically close by. For example, Mayo Clinic or National Jewish in Denver, and they can arrange for a virtual video visit with the patient. They can review the medical records online, through electronic medical record system, they can see the images and then they can talk to the patient. That basically saves the patient a trip to the center. Some of them may not have the ability to go there because they are not they may be on a lot of oxygen, and so that's how second opinion visits are done on video visits. Coming to imaging studies, again, a lot of tests can be done remotely because the physician does not have to be in the place where the test is performed, like pulmonary function testing. It's done in a PFT lab. Similarly, a lot of chest imaging, whether it is CT scans, chest X-rays, PET CT scans, all these can be done at a site that is closer to the patient, and then the image results and images can be interpreted by a physician who is far away remotely. Similarly, blood samples, sputum samples, all these can be at least collected close to where the patient lives, shipped off to a referral lab. The testing results can then be shared by the provider to the patient in the remote visit. So this is a graph that was actually showing the trend of telehealth visits. If you look at the top of the graph, there is a dotted or a interrupted green line. That green line is the actual in-person visits, and the bottom one is the telehealth line, which is the telehealth audio line, which is the red one, and then there is telehealth video line, which is blue one. And what we see here is that after the pandemic had begun, after COVID had begun, initially there was a significant and a precipitous drop in the number of in-person visits. It went from like 100% in mid-March to by mid-May, it was down by about 20 to 25%. At the same time, uh, telehealth voice call visits started increasing. But if you look at the general trend with the video calls, it did not even pick up. Part of the reason for this was there was kind of some grade of delay by CMS to approve the payments. So nobody was venturing into doing a full video visit um, with all the facilities that are required to conduct a video visit until later into 2020 and early 2021. So these telehealth visits or the video visits, they all need a secure communication channel. When I say secure, it has to be encrypted on both ways, encrypted for audio, video, images, and it has to have ability to manage HIPAA compliant material. So that is the reason why it was not easy to just start and run with the program. Although everybody has cell phones, it's just not safe to use. It's not recommended to use any non-proprietary softwares that are not HIPAA compliant, as it increases a lot of patient privacy issues. So this is um, um, a graph, or this is actually a prevalence ratio of how PPE was being used when flexible bronchoscopy was being performed during the COVID. And with proper PPE used, when we do bronchoscopy for lung cancers, the risk of COVID transmission was 0.001%. So what this indicates is that PPE requirement was important. That means for every 1,000 patients we see, there was a one patient chance of exposure to COVID. And hence, physical examination and in-person visits actually decreased. Moving on to use of the telehealth in lung cancer. Again, in lung cancer, we do what is called as multidisciplinary thoracic tumor board or oncology telehealth board. So what this means is for a patient whose cancer care has to be provided, typically here at Mercy, we do it every Wednesday morning. We all meet virtually and we discuss the case, we discuss the presentation, we discuss the actual surgical procedure where or the diagnostic procedure where we get diagnosis. Then we review the pathology with the pathologist. Then we go through rest of the staging workup like PET scans and MRI scans. And finally, we discuss with the oncologist as to what would be the best possible treatment for that patient. Similarly, remote cancer care is provided from referral servicing institutions, either through telephone encounters or through televideo encounters. Next topic, if use of virtual care in pulmonary medicine, is in asthma. So asthma is a very common disease. It's more common in children, as in adults, the prevalence kind of goes down, and sometimes it is admixed with adults who continue to smoke, and then it kind of presents more of a COPD, less of an asthma, and sometimes as an overlap in between. Now, in asthma care, inhaler education plays a very important role. When patients don't know how to use their inhalers properly, despite the best medications we write, they may not have effective improvement in the symptoms. There are inhalers which are able to connect to the web. They can communicate with the physician's office. They can tell if the patient has been doing their inhaler therapy well at home. Similarly, they have reminders with apps that can kind of pop up and give a reminder to the patient. Similarly, we can use a in-home at uh, uh, spirometry device that the patient can just do it at home, and we can monitor their peak flow rates, which helps us in kind of identifying people who are at risk for developing asthma or an asthma exacerbation. Similarly, video monitoring can be done during an exacerbation when patients are having significant symptoms. They are at home. We can monitor them through a video encounter and then see how bad they are doing. We can actually look to see if they are having significant dyspnea, any use of accessory muscles, any use of abdominal muscles. And if we see that, then we can tell them that they need to actually activate EMS services so that they can be brought to the hospital. The next one is asthma action plan. So asthma action plan is given to all patients who are having frequent exacerbations. What this involves is step-by-step approach of how to identify when a asthma exacerbation episode is occurring, how to take medications during an episode, how to use the inhalers, when to use a nebulizer, how when to use an oxygen, and when to call for help if the patient is not getting better. So asthma action plans can also be implemented through virtual care. Next topic is COPD. Again, a very common pulmonary disease. Here it is useful for the inhaler education and for exacerbation identification. So COPD is chronic obstructive pulmonary disease. It is a disease which is triggered by exposure to irritating agents or irritants. Most common cause in the United States is cigarette smoking. And the the effect of the pollutants enhances the existing risk with smoking. So urban air is a trigger for COPD worsening, and those worsened episodes are called as exacerbations. So how virtual care is useful is it helps in identifying patients who are at risk for exacerbation, and then it keeps an eye on them while they are actually getting treatments at home to see if they are maintaining stability or if they're worsening. Next is pulmonary rehabilitation. Pulmonary rehabilitation is like physical therapy, but for the lungs. They involve a lot of lung exercises, muscle exercises, balance exercises, which help in improving symptoms associated with chronic lung disease, especially COPD, pulmonary fibrosis. And in those patients, they do exercises at home, and the instructor can kind of guide them uh, from the remote site. It's like somebody who is training with Peloton through a advisor who is virtually available. So it's kind of a similar concept. Next is interstitial lung disease, or ILD. And then in ILD, again, it is not as common as we would see in COPD, but ILD does happen, and there are several varieties of ILD. Close to 200 close to 200 different types of ILD varieties are available. And not all pulmonologists may have the ability to kind of diagnose and treat these patients because they are all different varieties. And in those practices, what they do is they can join a virtual telemedicine access center where they can discuss the case with another provider, and then they can come up with a treatment plan for the patient locally. Next is use of virtual care in lung transplant and in pulmonary hypertension. So, lung transplant and pulmonary hypertension are advanced lung diseases. These are not available, for example, in the state of Missouri. It's not available anywhere else except for Barnes Jewish Hospital. Now, pulmonary hypertension for certain cases that are not severe, that means that are moderate to mild category, can be managed locally, but anything that is severe again has to go to Washington University in St. Louis. So how virtual care is useful for these patients is because they need a lot of follow-up. It's not easy for them to go all the way to St. Louis for a 15-minute office visit. They do a lot of virtual care support, and this can help with monitoring their medications. It can help in monitoring their home spirometry testing. It can help in adjusting the medication doses, and for assessment of remote quality of life, where instead of going to the office, the patient basically performs activities at home, which the provider can then review and see if they are meeting their functional capacity goals. Okay. Next is pulmonary rehab. I talked about this a bit earlier. Here, pulmonary rehab is provided to both the IPF and the COPD groups, although other groups are also benefiting from it. Medicare predominantly covers IPF and COPD. And the pulmonary rehab can be done at home using home exercises. It can include home oxygen education, smoking cessation education, nutritional improvement, and with psychosocial support. Any questions up to this part? Okay, looks like no questions. I will proceed. Next is inpatient care. In inpatient care, especially virtual care is useful for rural hospitals. Hospitals like in the Mercy system, we have hospitals in Mercy St. Francis and Aurora. They do not have a staff pulmonologist who is available to round every day. So for those patients, we tend to provide virtual consultation services where we can log in into the camera and monitor screen system into the patient's um, device in the hospital, and then from there we can kind of coordinate as to what kind of investigations they need, or if they need any specific directions with regard to the advanced specialties. It is also useful when there are worse weather conditions, especially in places which are in the high altitude in Colorado, in Utah, or which are remotely far off, like in Alaska. And they are also used in healthcare underserved areas, and in underserved populations like the Indian healthcare system and the VA system. Okay. Before I go to critical care medicine, I just take a 1 minute break. I'll just get a cup of water. I'll be back. If you guys want to take a break for 2 minutes. Okay. So for the next part, we want to do critical care medicine. So Mercy as a healthcare system has a dedicated virtual care center. This provides inpatient hospital services for uh, support systems like Mercy. This is located in St. Louis. It supports some hours in Springfield, especially the night hours. Then it supports multiple rural hospitals and critical access hospitals. They also have a critical care medicine hub, which can do virtual ICU coverage also. So all the patient rooms have a camera through which the physician can see the patient, and they can kind of talk to the patient's nurse as to what kind of medications have to be given or what kind of tests have to be done. They do provide virtual ICU care services for cross coverage for Mercy Springfield from St. Louis. So a typical uh, um, setup in the telecritical care office would look like this, where the patient would have, where the physician would have access to the telemetry, to the cameras, to the radiology suite, to the epic medical records, and typically they have a chart open where they are writing notes or putting in documents. And how these work is there will be a central location or a central location that can provide services to multiple surrounding areas. So this works with what is called as a hub and spoke model, where the hub provides support to the nodal points, and the nodal points will then support the smaller spokes. So in tele-ICU, tele-ICU also has been becoming more and more prominent. This is during the pandemic, where we had tele-ICU services developed for managing patients because there were just not enough doctors available. So instead of going to the other hospital, we would just manage them from here. For example, at Mercy, Lebanon, which is about 40, 50 miles from Springfield, we would manage their patients and provide critical care decision making capacity right from Springfield. Second, tele-ICU services are useful for continuous monitoring of patient progress. For example, when we tell certain medications or pressors to be given to patient, they can start. We can start, and then they can monitor, make sure the patient is moving in the right direction. Similarly, they help in improving compliance to best practices. For example, there can be virtual for checkups on are patients getting uh, PPI or H2 blockers for intubated patients? Are they getting DVT prophylaxis? Are we checking their blood glucose sugars levels every so often based on the protocol? So for those kinds of best practice methods, tele-ICU is useful. They can also help in rapid response and in code blue services, where the provider on the tele ICU service will actually help in running the code or in addressing the rapid response. Tele ICUs can also be used for providing education. Now, in a typical ICU, half of the staff will be out on time off, or they may be on the opposite shift, and the remaining half will be in the actual ICU. In those scenarios, it's very difficult to provide education to all of them at the same time, and hence we use virtual services like how we are doing today. Um, Tele-ICU also helps in performance improvement. So what I mean by performance improvement is in the ICU, we monitor a lot of things. For example, central line associated bloodstream infections or CLABSIs. Then there are catheter based infection rates for Foley catheters, and those are called as CARTIs. Then there is ventilator associated pneumonias. All these are very, very carefully measured and followed to prevent them, because uh, they all end up with poor patient outcomes if there is a CLABSI or a CARTI. Tele-ICU is also helpful in providing multidisciplinary rounds, like how we used pulmonology. I was using it for uh, thoracic oncology cancer care. Similarly, multidisciplinary rounds can be done in the ICU. And then stroke and telestroke has also become prominent, where it is providing these services uh, for identification of stroke early, so the TPA can be given. So most ER docs are supported through neurology through this tele-ICU system. Okay. And then the last topic in pulmonary critical care medicine is use of telehealth in sleep medicine. Now, in sleep medicine, it can be used for monitoring of home invasive ventilators, home non-invasive ventilators, and then in treatment of certain hypoventilatory and um, neuromuscular diseases, like in case of Duchenne's or in case of myasthenia gravis, where it can be used at home. Now, troubleshooting the circuits and alarms. This may also be done from a office without having the device in our direct position. Most of the new CPAP, BiPAP machines that are used at home talk to the internet, and we can change the settings on the go without the patient even coming to the office. So these are a couple of examples. The one on the left is called as an AirSense Elite, and the one on the right is called as the AirSense 11. This is just examples of devices that can be monitored over the cloud, or that can be monitored through a integrated network system. Now, the advantages are um, patients can essentially stay at home and they can see multiple providers on the same day when they're getting virtual care services. Similarly, once patients are being seen on time, it definitely helps in delaying or preventing any further delay in care. It also reduces cost of travel, it reduces time of work, and it is tailored to the individual. It can be done across platforms. What I mean by across platforms is it does not done only for like Epic. We can work across different platforms with different providers and sometimes with different systems also. And then it reduces the cost of healthcare because there is less uh, face-to-face time that is needed compared to the virtual visits. And it is time and place agnostic. What does that mean is it does not depend on which time of the day there is an availability, because most of these are just virtual visits. And then lastly, in healthcare shortage areas, it is useful because it provides care to places where they would never ever have somebody who would provide that particular service. Okay. Then there is a special population which is FedMed. This is the federal prison population. There is a large federal prison in Springfield, and they receive their care through physicians who actually provide services through virtual care. The Some of the prisoners have high grade security; they cannot come out of the facility. So for them, we just do the telehealth or the virtual visit services. Now, if you look at the barriers for telehealth, one of the biggest barrier is familiarity with technology. As patients are getting older, not all of them may be having familiarity with certain devices that are more commonly used by the younger part of the population. So that's a big barrier, technology. Then, if you look at the type of insurance, the primary payer insurance, both Medicaid, Medicare, and in commercial, we can see that there is a trend where it is more in line with the commercial insurance, where the reimbursement rates are good compared to Medicare and Medicaid. The other biggest barrier is lack of broadband service. So when patients are in remote areas, sometimes they don't have good cell phone signal, and then their internet is kind of a dial-up internet, which is very, very slow. So they need to have broadband service. So future directions, virtual care can enter into AI, and it can involve in decision making automatically with virtual thermometers, with virtual stethoscopes, and with virtual digital EKG watches, sleep device monitors. Essentially, they have a lot of role moving into the future. And as demand for healthcare will be increasing, demand for the associated services will also increase. Okay. Any questions?
Hi there, I have a question. I was curious if when you're offering tele ICU, is there another doctor in the room there, or you're offering that uh, as the sole provider for that hospital? And
Go ahead.
go ahead.
Yeah, so typically in tele ICU visit, especially at night, there is no doctor in the room. That's the purpose of the telehealth, because there is no doctor in the room. Somebody else, which is the telehealth doctor, will be on the room. And sometimes there is no doctor, but there may be a nurse practitioner, and the nurse practitioner may need additional help in decision making. At that time, they can call virtual ICU.
Okay, thank you. And the other question I had is if you do have concern with things like uh patient ability to understand the technology that they're using, and if you've ever like run into issues or foresee issues even with like the virtual stethoscopes or otoscopes and stuff that you discussed, whether there's a difficulty in how those are implemented because of patient knowledge or ability.
Hmm. Yeah, so there are ways we kind of try to address that. One is we generally give patients an ample time that we are going to have a virtual visit, and we generally ask if their children can assist them in the setting up the appointment. Most of them are on their healthcare power of will, and they will help in kind of setting it up. And for those patients who have no way that they can use any technology, we just bring them back into the office.
Thank you.
Anybody else? Anybody else with any questions? Okay, so that is the end of my presentation.